Good day, listeners. Today is June 23rd, 2021. This is Renee Rosati, a member of the Public Affairs Committee of the North American Spine Society and a recent graduate, as of last night, from the Physical Medicine and Rehabilitation residency at Vanderbilt. I'd like to welcome everyone to the next installment of our new podcast series showcasing interesting articles from the upcoming Spineline magazine. Today we will be discussing the article by Dr. Akhil Chhatre, Dr. Adam Amir, and Dr. Laryssa Richards, titled Ask, Preoperative Safety Checklist Protocol in Interventional Spine Procedures, a Quality Improvement Study, in the May, June 2021 issue. You will have the pleasure of hearing directly from Dr. Akhil Chhatre and Dr. Laryssa Richards today. Our hope and goal is that this discussion will further expound on their compelling article in our upcoming magazine. So let's get started with some introductions. Dr. Chhatre and Dr. Richards, can you tell us a little bit about yourself before we move into our discussion?
My name is Akhil Chhatre. I'm an assistant professor at Johns Hopkins with physical medicine, rehab, and neurosurgery. I'm the director of spine rehabilitation, and I'm also the fellowship director for the Interventional Spine and Musculoskeletal Fellowship. My clinical area of focus is on spine and musculoskeletal rehabilitation, and we offer services that manage and direct physical therapy, medication management, and interventional care at Johns Hopkins.
Excellent.
Hi, I'm Laryssa Richards. I'm one of the physical medicine and rehab residents. I currently do a little bit of everything on the different rotations and am applying for sports medicine fellowship this year.
Awesome. Best of luck to you. It's a good journey.
Thank you.
So let's dive into the article. Again, the article is entitled Ask, Preoperative Safety Checklist Protocol in Interventional Spine Procedures, a Quality Improvement Study. Now, your article mentions two checklists which inspired this quality improvement project. Could you tell us why each of these checklists were developed?
Sure. So in the 1990s, there were several reported events, and one of them being where a wrong leg was amputated. And at that point, reported cases grew and grew, and that eventually led to this universal protocol checklist. This checklist involves preventing the wrong site, wrong procedure, and wrong patient surgeries. So it's those three steps that are involved, and a pre-procedure verification process, marking the procedure site, and performing a timeout.
Okay.
Shortly after that, the WHO created a surgical safety checklist in 2008. It's kind of an extension of the universal protocol in a sense that it's just more extensive. It includes ways to reduce adverse events such as surgical site infections, retained instruments. It's just a piece of paper. It's a checklist. It's very affordable. So like low-income countries and different places can use it, and it can help reduce complications and deaths from surgery.
Awesome. Tell us a bit about the history of the timeout.
Yeah, so the definition of a timeout, according to the Joint Commission, is an immediate pause by the entire surgical team to confirm the correct patient, procedure, and site. So what that statement doesn't really mention is how long do you have to take for that timeout, who needs to be like paying attention, or how much attention do they need to be taking? Does everyone have to say, I agree, those words? But what we do know is if that is performed correctly and in the right fashion, then checklists in this timeout really do work well.
All right, well, let's dive into what you guys did. Dr. Chhatre, the quality improvement intervention that your team implemented at two of the Johns Hopkins outpatient surgery centers from August 2020 to August of 2021. As it's still ongoing. It was really interesting. I felt like it was a new spin on something that a lot of proceduralists already do, which is the timeout. Can you tell us why it's important for interventional spine providers to have a unique checklist of their own?
Yes, thank you. There's many factors why I think it's important for there to be something a little bit more tailored to the interventional spine provider. One, there are providers that do a lot of volume of procedures, and it's easy to get lost in muscle memory, so to speak. You come in, you prep your tray, you prep your kit, you get your medications, and if you have a lot of bilateral cases one day or a lot of cases that are on the right side, you might just get into that groove and that rhythm. And that mistake cannot just be made with the person doing the procedure. It could be with the nurse or the tech in the room or the radiology tech or whoever trainees you might have. So, there can be a breakdown at any one of those levels. The other kind of intangible here is that you want a good team in place. When you have a good team, you tend to have a rapport. When you have that rapport, you can have a breakdown in the system, so to speak, because you might have implicit trust with the other folks in the room. So they might say, oh, Dr. Chhatre knows what he's doing, or I might say my nurse knows what, they know what they're doing, and we're all on the same page. Well, that's where you invite opportunity for error. And then other factors to consider is you might be doing multiple things at the same time. You might be doing, a knee block, and you might be doing a procedure in the lumbar spine. And it's important to be very accurate because one needle in the wrong place is a needle in the wrong place, and that would be considered a wrong site procedure. And that's a sentinel event, and in our institution, those are considered non-events, meaning they should not ever happen. I think it's important for, if you have a high volume practice, if you have a busy area, busy setting, so not just, your caseload may not be a lot, but if there's a lot of other procedures going on in the suite or that building, it's just inviting opportunity for error. So that's why I think it's important for interventionalists to have something a little bit more tailored and not just generic.
Yeah, I definitely see your point with maybe the casual relationship between coworkers in that operating room. You get very friendly with one another, and there is a lot of trust, and some of these procedures are repetitive. Those are all very interesting points. What are some common mistakes that you see potentially happening without the use of a standardized checklist?
So if you don't do something with structure, if you don't do something the same way every day in the same structure, then I think you are every part of your prep for doing a procedure is an opportunity for error. So if you don't check the wristband, check the name, the date of birth, go over allergies, if you don't do everything kind of the same way and have the same things that you're checking off, I think you're inviting opportunities for an error. A good example of this is if somebody has an allergy to ChloraPrep or chlorhexidine, which is a prep. So if you are routinely checking allergies when you're in the room and you might already be prepping the patient, you have invited error. So I think it's important to check allergy checklists, before you do the procedure. Maybe have a system in place where you do it in the bay, the pre-op bay, before you bring the patient back. So that's an example of why I think it's important to do something the same way every day. Yeah.
Definitely. Well said. Dr. Richards, how did you go about designing the methods for your study?
Sure. So the ASK portion stands for Ascertain Site Knowledge, just to start with that. The aim of our study was to perform before every procedure a 30-second timeout, including the attending physician, Dr. Chhatre, the interventional spine fellow, the radiologist technician, the nurse, and then the anesthesiologist if they were present for the case, and collect the data on the wrong site, wrong procedure, and or wrong patient surgeries. This timeout and ask included the laterality to the marking that was placed on the patient by the attending, and then each team member would have to agree with that and wait 30 seconds. This allowed time to process all of that information too. And you waited 30 seconds each time, even if everyone had already agreed, which I think, slowed everyone down for that brief moment and really captured everyone's attention, which is important in the timeout.
Yeah, I found that really interesting, that mandatory 30-second timeout. Was that on a timer? Was it a real 30 seconds, or was it kind of till everyone agreed on the laterality?
We have a clock in the room, and so it tells us the humidity and the temperature and the time in seconds as well. So we use the clock. It's the same thing that JACO does when they come and they're monitoring you. They're literally looking at the time, if you have it in the room, or their own watch, to make sure that you do it the same way.
Okay. So your study period hasn't quite ended yet. You're still going until August of 2021. How many procedures have been a part of this study since August of last year to February of this year?
Sure. 1,106 were completed between that time frame. And so we are planning on continuing it until August of this year.
Awesome.
For a year total.
And can you tell us what the results of your intervention have been so far?
Yeah, there were 0 near misses or incidents thus far.
That's superb. That's a successful quality improvement study, huh?
Yes.
Dr. Chhatre, in terms of improving patient safety, it sounds like there's not much of a downside to implementing this checklist. However, what do you see as barriers for other practices in other parts of the country trying to implement a checklist in their procedure suites like this?
So, my dad would always tell me, you can't straighten a dog's tail. And, we're a product of our training. So if we train in a certain environment in a certain way, it's very difficult to change unless there's some type of motivation. And we tell this to our patients that come see us in spine clinics as well, right? Pain is a motivator. So if there has to be some reason that you want to take action. And I think that, demonstrating really good quality improvement projects such as this and showing the success, I think
There's a quality improvement study
of a nurse, of a radiology tech, or a physician you might be, how great your clinical skills are, opportunity for error can still happen to anyone in any setting. And I think that if health systems did open up and show some of their sentinel event data like this, even the best institutions still have across the board have these wrong sites occur. This is why I think it's gained so much attention even within us as a community at NASS. I think that it's professor at Johns Hopkins with your colleagues. I think part of that discussion should be patient safety and the lack or reduction in errors. And so I think that should be part of the conversation when it comes to what barriers might be. Unfortunately or fortunately, there's going to be folks out there that have not encountered any such issues in their practice, and it's going to be difficult to implement. They'd say, well, if it's not broken, why do I want to fix it? But yet we all do timeouts now. And we do timeouts now because of errors that occurred to other folks, unfortunately. But we all do timeouts now because we realize the utility of how important safety is.
Yes, the most importance. Dr. Richards, do you have anything else you'd like to add to that comment about any barriers you foresee happening with this checklist?
No, I think one of the things that you can read about in the literature, probably more towards surgery, but can be translated towards this, is that the teaching is important in education. So we're doing this now for this yearly study, but maybe having like a yearly education that we are going to continue to do this 30-second timeout and why it's important with all staff is the kind of the second part, and making it a must instead of an option. And maybe a year, every 2 years, something like that, like similar to what we have to do with different modules. But just education-wise with the staff can be very helpful.
Good. So it sounds like it's going to continue at your institution after the quality improvement study period ends.
I believe it will. I will also say that I was speaking about culture. I think that what the change that I've seen since we've started this is that everyone in the room has now taken a sense of personal responsibility for what is the right, procedure, the right site, all of those things. While before, I didn't see that. That level of engagement, I think, at the end of the day, has a net cumulative effect for outcomes in terms of satisfaction for the patient, how they feel like everybody's engaged in the room, as well as safety. So I think that having that sense of personal responsibility, regardless of who the attending on record is leads for a better outcome for the patient.
Yeah, it sounds like the team dynamic is really uplifted by engaging and giving everyone a little more autonomy and responsibility to acknowledge this is the right side, this is the right place. All right, well, I believe that wraps up the questions for today's podcast. Do you guys have anything else you'd like to add?
No.
So much for your time and interest in this endeavor that we took upon.
Yes, thank you for having us.
We're so honored to have you guys. We're so grateful that you submitted this quality improvement study to our Spineline magazine. To all of the listeners who tuned in, thank you for joining us today on our NASS Public Affairs podcast. We'd like to acknowledge the help from our wonderful behind the scenes NASS staff who make these podcasts possible: Jeff Carson, Pamela Town, and Brianna Schaefer. I'm Renee, signing off from Nashville, Tennessee. And don't forget, stay spine safe.